Okay. Good afternoon or good morning, depending on where you are. Welcome to our webinar about FTCA. I am Jeff Adest, along with Sandy Jensen. I think many of you have heard us speak before. You might think it's a little bit strange that we're doing this in December, when the application is usually not due until June or July. The reason that we're doing that is because Sandy has been driving me crazy that we get to a couple of weeks before the webinar, before the application is due, and all of a sudden people are reaching out to us and saying, well, I don't know how to do this, or I didn't do this the whole year. How do I fix it now? And in order to avoid some of that, Sandy convinced me that we should do it now so that you might be 6 months into the year, but at least you can have 6 months where you're doing the right things instead of only a month and having to try to figure out how to wait to make that retroactive for a year. We are going to walk through the requirements today, but I guess just a couple of overall high-level thoughts. Number one is that, in case you have not seen this, HRSA has removed FTCA from OSVs. Right, that there was always a large part of OSVs asking questions about it. Now going forward, they are not supposed to be asking any of those questions. As Sandy pointed out to me, what that really means is that the risk management and claims management pieces are out, but the QA pieces and credentialing pieces are still in, which is a significant part of FTCA. But some of it is out. The other interesting thing that's happened is that historically, right, so I'm going to say in May, they issue a new PAL, which has all the requirements. And if you want to know in the middle of the year what to do, you have to go back maybe to last year's PAL and not to this year's PAL. They have actually issued a document this year, which is available on their website, called the FTCA Step-by-Step Guide for Completing the Application. We don't know for sure if that's what's going to be required next year, but most likely it is, and there are some new things in there which are a little bit crazy, which we're going to go through today. I should just mention, I'm sorry, I forgot to mention this at the beginning, right? The session is being recorded. We will send out the slides after, as well as a recording of the presentation, so you don't have to put into the chat or the Q&A, can you send the slides? We will send it. You don't have to be sitting there with your phone and taking pictures of the screen of the you know, all the slides, because we will send it all out. One of the things that I just want to point out, and I'm going to let Sandy walk through most of it, is that for those of you who have been at FQHCs for years or have heard our webinars, we used to talk about how there's a requirement, right? If you send a patient to the hospital, you have to be able to track them. Before, I want to say about 3 years ago, there was a requirement for a few years where if a patient came to the hospital, even if you didn't send them, you had to somehow know that through ESP or some other way of knowing that and be able to track them as well. HRSA thankfully had taken that out. However, in this new step-by-step guide, it is back in again, and which arguably means that next year it will be a requirement again. I don't have a good way for how to deal with it. I want to point out that they have added it, and they've added some other things that Sandy is going to walk through. So at this point, I'm going to turn over to Sandy, who's going to walk through the requirements, and I will jump in here and there with some comments.
Okay, great. If you've ever joined one of our webinars before, you know that we have very detailed slides. And that's because when I go to participate in a webinar and I go to refer back to the presentation materials, it drives me crazy when I see just a bullet with one word and I try to recollect what people said about it. So our slides are really detailed, so you could use it as a reference going forward. But we're not going to go through and read each slide, word for word. But again, you could go back and look through it yourself. And if you have any questions, please feel free to reach out. We're always happy to clarify something. So in some things I'll spend a lot more time than others, like risk management, spend more time than claims management, but we'll try to get through everything. So the Federal Tort Claims Act, basically it provides you malpractice coverage for a health-related claim. and it provides coverage for your FTCA deemed employees. And so what that means is if there's a lawsuit or a malpractice action, it's against the federal government. It's not against the health center directly. So that saves you a lot of money, and you have the government stepping in to defend you. So every year, in order to get this coverage, you have to submit an initial and then a redeeming application. Usually the PALs come out in like February, March, and they're due in June or very early July. And so, you know, again, Jeff was absolutely right. The reason why we're doing this is because we review so many FTCA applications, and by the time we get them, you know, it's hard to go back and be able to document things that might not have been included in your assessments or meeting minutes or your annual report, trying to summarize the things you've done all year, but there's not a lot of documentation to back that up. So the purpose of this is to make sure you're documenting what you have to now to prepare you for the FTCA application. As Jeff mentioned, there's a step-by-step guide. It's like 90 pages that goes through every question in the application. And, you know, right on the guide it says these are not to be considered requirements, but they're more like guidance. However, if you look at other things on the website, including like webinars and other samples that HRSA provides on their website, they seem to be following this guide. And if some of you participated in, I believe HRSA had a multi-day FTCA meeting in May, they really used the things that were in this guide as examples or of things that FQHCs should be doing. And so we thought it was good to incorporate some of the things in this guide because they establish new requirements or they change guidance from previous years. And Jeff mentioned the one about the hospital tracking. So why is complying with FTCA or getting FTCA and meeting your requirements important? Because if you lose the FTCA coverage, then you have to represent yourself for malpractice actions and you have to purchase your own insurance. And as Jeff had mentioned, that they'll no longer be looking at the FTCA specific requirements from the compliance manual, but instead they'll be tracking your compliance through these deeming applications. So what that tells me is they're going to be taking a closer look at what you submit, or they could be doing more FTCA specific on-site visits. And for those of you that are participating, and I know a few of you that we represent have been through these FTCA site visits, they're horrendous. They're extensive, in-depth. They look in your refrigerators. So, you know,
right. It's basically think of an OSV and, you know, quadruple it is what going through an FTCA site review is. Even though it's only 4 topics instead of 20, they are much, much more intense.
Right, right. So the purpose of me bringing that up is that you really want to be prepared, and you want to do what you have to do throughout the year so that you're prepared for the deeming application and if you're subject to a site visit. So we'll do risk management first because that's the most intensive. So the risk management plan, there's a requirement that FQHCs have a risk management plan and risk management operating procedures. And the plan just lays out what is your system in place that outlines your risk management program throughout the health center activities. And that includes, you know, training, completion of quarterly assessments, and your reporting to the governing board. Now, important points that are indicated in the guide is this plan has to be reviewed annually. It has to be presented to the governing board and have them approve it. And they said it should be a separate document from your risk management operating procedures. Now, and I know that for many of you, it's one document. It's the risk management plan that outlines your policy, your system, and it includes operating procedures. but this guide notes that it should be 2 separate. So your operating procedures, those are your step-by-step procedures or activities for how you're going to ensure that your risk management plan is working. So how you're going to control risk. And so that includes your tracking policies, identifying, reporting, and tracking near misses, incidents, sentinel events, and the other things listed. And these are, consistent with HRSA, your patient grievances and satisfactions. You should be tracking those on at least a quarterly basis. You should be setting annual risk management goals. And then throughout the year, track how you are at meeting those goals. And then your procedures have to include an annual risk management report to the board. The PAL requires you to upload your tracking policies, and they're the most focused on referral tracking, hospitalization tracking, and diagnostic tracking. So with referral tracking, HRSA requires you to include certain elements. And before I go into this, we always get a question, where in the compliance manual does HRSA require that blank? So your referral tracking policy include all of these, or your diagnostic policy include all of these. And it's, you can't just look at the compliance manual, because there's requirements or clarification given through webinars. Usually annually they do the FTCA PAL webinar, and so they spell out more requirements there, or in this guide, or in other guidance that comes out, or sometimes we'll get guidance through an OSV, and sometimes they conflict. So, you can't just look at one thing. There's a lot of different sources of information where you would come to learn HRSA's requirements. So from the guide, you can look at the guide with this one as well. In their webinars, the referral tracking policy has to include certain elements, and they're listed. Basically, what they're looking for is a closed loop system. So from the initiation of the referral to sending the information to the referred to provider, following up to make sure that the referred to provider sends the evaluation report back to you, and then that the evaluation report is received by the provider that initially referred the patient. So these are the elements, and they're also, notes some things that the guide includes. So you have to include specific time frames for transmission, and that depends on whether it's like an urgent or a routine referral. So some policies will say urgent referrals, you expect follow-up within 3 days or 5 days or 7 days, whatever is reasonable. And then non-urgent or routine is sometimes, 2 weeks, 3 weeks, 4 weeks. You just have to specify clinically what's appropriate in your referral policy. Now, identify titles of staff who are responsible for each of the duties. Sometimes I see in the policies that'll say designated staff. Here they're looking for titles. I don't know if they're going to be a stickler for that, but that's something that was taken out of the guide. So to the extent that you have a referral department or you have set staff that do this, maybe the medical assistant or someone else, then they are looking for titles. And along with the risk management plan, the referral tracking policy also needs board approval and signature. So hospital tracking. Here are the elements that HRSA has required for the hospital tracking policy. So patient information, date of admission, date of notice, documentation received or requested, any follow-up you initiated. In here too, the guide said that you must identify the staff members by title responsible for receiving the admission information, who has the responsibility to follow up. So this is what Jeff was referring to, which gets him all fired up, because, the compliance manual, they actually acknowledge that it would be hard for an FQHC to track hospital admissions of patients that went in on their own. And so they were removing that requirement. but here it is again in the guide.
Right. I will say that for any of you who have negotiated, column 2 and column 3 contracts, I'm sure you've had to rip your hair out to try to deal with people explaining why you need this language in there about access and audit and providing you with financial reports. I think that's, the easiest thing in the world compared to going to a hospital and trying to convince their lawyers to sign a contract that says that they're going to notify you every single time an FQHC patient walks through the door. It's become virtually impossible. I would encourage anyone who is on this webinar to send an email to HRSA saying, we saw this in the FTCA, step-by-step guide, and if you're going to require it, it's going to be impossible for us, so please don't go back on your word where you said you weren't going to do this again. Don't use those words, please.
Okay, so the diagnostic tracking policy, so that has to include both lab and radiology. If it doesn't include one of this, then it won't meet HRSA requirements. And so there's specific information here too that should be tracked, and it should be in your, so when I say these are elements that should be tracked, you have to list them in your policy. So, our health center tracks the following elements, and you list the bullet. So communication of results to the patient, you also have to document where you've been unsuccessful in communicating with the patient. So if you called on December 19th, you would know December 19th, contacted patient, left a message or something to note that it was unsuccessful in reaching the patient. So through webinars, in prior years with completing the FTCA application, and during OSVs, HRSA made clear that all results, including normal results, had to be communicated back to the patients. Now, you don't have to do it in the same manner that you would do critical or abnormal, but there should be some manner of communicating back to the patient. And the guide adds a requirement that if you have contract for lab services, then your contracts should spell out, what are the critical lab values and what process is in place to communicate those lab values back to, or the critical result back to the FQHC. And if you do it in-house, then your policy should refer to your lab policies, which also define critical lab values. And what they want to see is that, if a lab comes up with a result that is critical, there's some sort of quick communication back to the health center or to the provider who ordered the results. Usually it's a phone call to say what the results are so the provider can quickly contact the patient. For abnormal results, your policy has to include the acceptable means of communication, whether it's verbal, electronic, the time frame. For abnormal results, that time frame is usually, it's not as critical as the critical results, so it's not the same day, but you could have maybe 2 days, or, it depends on clinically what's appropriate. And then here are the elements for the critical results. I mentioned a few. The measures to contact the patient. In the past, they've required, if you can't contact the patient through telephone, multiple attempts at telephone, they have actually required that you consider a home visit or having contacting local authorities to go to the home and try to contact the patient that way.
Right, I think this year is the first year where they've set specific different guidelines depending on the level of how critical the results are, normal versus abnormal versus critical. They want you to have policies that address each one of those separately. So it can't just be generically, we try to call the patient for 2 days and that's it. It has to be different for each one of those categories.
Right, and your policy should include assigned responsibility, so someone has to be responsible for this, and someone has to, have this as their job duties to, acknowledge receipt of results, let the provider be aware, notifying the patient, documenting attempts to contact the patient. And this, like the other tracking policies, needs to be approved by the board and have the board sign off on them. Another big area is the annual risk management training. And so, this year they made some changes. Well, actually last year they made some changes to obstetrical training. Other requirements are infection control, HIPAA and medical record confidentiality, and specific trainings for groups of providers that perform various services that could lead to risk. So your dental department, you'd have a training for the dental providers regarding, maybe infection control specific to dental, or some other issues that have been popping up in dental that should be addressed in a risk management meeting. So the new requirement for obstetrical training. So, before your OB department required obstetrical training and electronic fetal monitoring or dystocia drills, and then they clarified that obstetrical training was also required if maybe you didn't do labor and delivery, but you did prenatal and postnatal care. So training was required there. And last year they said it's also required if you have providers that have contact with reproductive age patients for other clinical services. So, I reached out trying to clarify, and basically what they're saying is that there is risk in other clinical areas if a provider has contact with these reproductive age patients, and it's associated with pregnancy and childbirth. So the health center should determine, the appropriate training for these other providers, and your behavioral health providers might have different needs than your dental providers. And they also noted that ECRI has trainings that can help you meet these requirements. So basically, it seems like, who requires obstetrical training has greatly expanded, but the level of training differs based on who these providers are and what the risk areas are in that department. The guide notes that training is required for all clinical and non-clinical staff, and it states that everyone in the health center, no matter their role or department, must be trained on basic risk management functions. So you decide what the training is, but everybody should have some level of training on just basic risk management. So as part of your requirements for risk management in the PAL, you'll be required to upload your training plan, your tracking documentation. So for the tracking documentation, it has to include staff designation and credentials, and it can't be blank. So it has to list all of your staff, their titles, and then the risk management training courses that they took. It has to list out the title of each course. You just can't say completed all, yes or no, and the date. The risk manager also has to complete training, and that's something separate than what's in your risk management training plan. They have to complete outside health-related risk management training, and ECRI offers a number of different levels that can meet this requirement. So another area that is different in this guide is that you have to upload quarterly risk management assessments. That's not new, you've always had to do it. And usually meeting minutes were acceptable, and your meeting minutes could list out the different risk management areas that you looked at for that quarter. So, patient grievances, maybe your tracking policies. Did you do an audit and figure out whether there were any deficiencies in your tracking policies? And your meeting minutes would outline this, and it used to be acceptable. Now the guide says that meeting minutes alone are not acceptable. You have to show that you've done an actual assessment. So a self-assessment questionnaire, a targeted questionnaire, a checklist. If your leadership does walk-arounds through the facility and talks to staff, but they have to document and go back to your usually, you have a committee, and that could be the QA committee that talks about the findings. So these assessments have to document the results of whatever assessment you did. You evaluate the results, implement changes, and then you test the changes. And then you talk about it in the next quarter. And so the quarterly risk management assessments should be reflective of the entire year. So in quarter one, you did this. Now you're evaluating it, and you're doing something in quarter two. So they build on each other. And according to the guide, you should not submit quarterly risk assessments that do not require improvements, at least quarterly. So you shouldn't assess something that doesn't need to be assessed. You're assessing a risk area that you determined to be a risk area in your health center. And here are just some areas that you can look to. Your goals. Where are you in meeting your goals? And so you would create a questionnaire or a checklist. For example, if your goal is to decrease needle stick injuries, maybe you would do a walk around and talk to staff where the needle stick injuries were most significant. So here are some areas, but again, it's pertinent to your health center. What do you need to assess in your health center? So you have to designate a risk manager. You can have more than one risk manager. If you have different sites, you could have a risk manager for each site. Each has to complete the annual healthcare risk management training and upload evidence of completed training. So the annual report, so what HRSA made clear is you cannot just attach all of your quarterly risk management assessments and call that your annual report. You need to prepare a comprehensive report and submit it to the board, and that really shows where what you've been doing with risk management all throughout the year, where you started and where you ended. It really talks about so many different issues like claims, patient satisfaction, patient grievances, the tracking policies, your goals, how you did in meeting your goals, what are your goals for the next year. So it really has to be comprehensive. Also, they love graphs and charts because they think it's easier for the board to see your status and how you've done if you use a graph and chart. So here are some of the topics that you can include in your risk management report. And again, it has to be comprehensive. And here are just some examples. Again, you're going to receive these slides so you could see these on your own. But I'm just providing examples of what a chart could look at. So if you look at your incidents, and in here I pulled some routine ones that I see. So needle stick injuries falls within the health center, incorrect immunizations. For dental, the wrong tooth will get pulled. And so you see how you're doing in quarter one, and then maybe in quarter one you've implemented some changes. Incorrect immunization, maybe you have someone verify it, and then in quarter two you didn't have any. So it basically makes it easier in chart form for the board to see where you started and where you ended up with. And for risk management activities, here's a sample of what can go into a report. You talk about what you did for training, patient grievances and complaints. You'll summarize the areas of complaints and grievances. Maybe do a chart on it. You don't have to go through each one. So in January, patient A complained about this. You don't have to do that, but you can say, we received 3 grievances related to staff courtesy at this site in January or in quarter one. Staff were reminded about, courtesy to staff and customer service, and quarter two, this happened, it went up or down. So you can summarize areas into quarters, but they want to see that most of these topics are addressed. Now with your risk management goal, an FTCA specific on-site visits, this is the framework that they preferred. So goal 1, increase patient satisfaction and wait times. How did you do in goal 1? Result. And provide information as specific as you can. Patient satisfaction was at 20%. By quarter 4, it went up to 60%. So we met our goal. And here are some more, just as examples. So to summarize, the risk management plan and the operating procedures, according to the guide, should be 2 separate documents. The board should review the risk management plan annually and should approve the risk management plan and all tracking policies. Risk management training is required of all staff, both clinical and non-clinical. Meeting minutes alone do not meet the quarterly risk management assessment requirement. And remember, you have to submit this with the FTCA application. So, you should be doing quarterly risk management assessments, which include you're assessing some area, you're evaluating the results, you're putting in place any action that you think is necessary, and then you're following up to see whether those actions actually helped you with respect to the area assessed. And there are new obstetrical training requirements for your other clinical staff who have contact with reproductive age patients. So quality improvement. If you recall in last year's PAL, I don't believe there was one thing that you had to upload in the quality improvement section. Maybe I'm wrong, but you no longer had to submit the plan. I don't believe you submitted the quarterly assessments anymore. However, HRSA notes all through their documents that they will see this either through, the on-site visits or FTCA specific visits. And they note that quality improvement and risk management really, they intersect quite a bit. For example, patient satisfaction and grievance for risk management is also important for quality assurance. So since they intersect so much, they don't really require a lot of documents to be uploaded in this section, but we'll briefly go through a few things. So your quality assurance program has to have a process for assessing patient satisfaction, patient grievances. You have to do periodic QA assessments on at least a quarterly basis. And you have to share reports with the board and key management staff. I have already said that. You're no longer required to upload QA reports or QA assessments, but you have to attest that they've been done. So the compliance manual requires that QA assessments be done by physicians or other licensed healthcare professionals under supervision and use data collected from patient records to ensure compliance with clinical guidelines, standards of practice, and utilization of services. So when you're pulling patient records to make sure that the services provided comply with clinical guidelines, and it has to be done by, this review is done by physicians, this is peer review. And so, while it's no longer, as of last year, it's no longer required to be uploaded with the FTCA. I mean, let's see what they do this year. This is a big area for us when we are helping health centers with OSVs, because these are peer review that has to be done on a quarterly basis. Some form of peer review should be done quarterly and meet these 2 elements. And sometimes, not sometimes, in all cases, if it's not done, it's almost impossible to go back and do it because you have to be doing it quarterly. So there's no way to say that, last year in June you did peer review if it wasn't done. Okay, all right, so let's see. So you have to indicate yes or no whether you, this is in QA as well, whether you've implemented a certified EHR system. And so you just have to maintain the confidentiality of patient records. And the guide clarifies that you have to have, for your HIPAA, you have to have designated a privacy and security officer, which almost everybody has. You have to conduct the annual risk management or risk assessments related to confidentiality practices. That's a HIPAA requirement. So you have to be doing that. It's an annual requirement. You have to follow up on problem areas identified. You have to document the efforts, and you have to make sure that your staff complete HIPAA training at hire and annually. And HIPAA training is required for risk management as well, so you should be meeting that anyway. So just to recap on some documentation requirements for quality assurance. You have to have a process for assessing patient satisfaction, hearing and resolving patient grievances, completion of periodic assessments, and producing and sharing reports on QI. So what we normally like to see is that you have a QI committee. Your QI committee has meeting minutes. The meeting minutes will talk about data and performance measures, but also the other HRSA required elements. So patient satisfaction. What are your patients saying about, your wait times, your interaction with your providers, your interaction with your staff? How are you doing with patient grievances? Are a lot of people complaining? These should be in your meeting minutes at least quarterly. Any quality initiatives that you're doing or implementing, and again, at least quarterly, your quality assessments. So your peer review, a summary should be in your QA committee meeting minutes. And then these minutes should be provided to key management staff and the board. So sometimes we see that maybe the medical director will just summarize quality initiatives to the board, but the meeting minutes never actually make it to the board. So the meeting minutes should detail these HRSA requirements, and then they should be given to the board. And for your reference later on, here are just some things that could help when you're developing your meeting minutes. Okay, so moving on to credentialing and privileging. So this is another big area for the FTCA application and also for on-site visits. You have to attest that you've implemented a credentialing and privileging process and operating procedures that meet the requirements of the compliance manual. You have to actually upload your credentialing and privileging policy. And they've said, they've given you what belongs in the policy, and they said if what you have to do, every single element isn't in your policy, then you haven't met requirements. They'll just deem that you have not met requirements. So all clinical staff have to be credentialed and privileged, including medical residents, students, volunteers, nurses, your other clinical staff, so your medical assistants and your dental assistants, even if your state does not require that these individuals be licensed or certified. So in New York, medical assistants and dental assistants aren't required to have any kind of license or certification, but they are in New Jersey. So in New York, you would credential and privilege them as other clinical staff, and in New Jersey, you would credential and privilege them as OLCPs because they are required to be licensed or have a certification. Your policies and procedures have to include all required personnel, except that if you do not have to include other clinical staff if you do not use them at all. If you don't use any unlicensed staff for provision of patient services or clinical services, if you don't use any unlicensed staff for them, you don't have to address other clinical staff. However, what I like to do is I'll note somewhere in the policy, maybe with a footnote saying our health center does not use other clinical staff, just so that they're aware that you know what the requirement is and you're not addressing it because it doesn't apply to you. So LIPs are basically professionals who can practice without clinical supervision. And they give examples, but it depends on state law. For example, social workers, again, in New York, clinical social workers can practice independently, but master social workers routinely practice under supervision. So if they're practicing under supervision, they would be considered an OLCP. If the professional does not require license or certification to provide services, then they would be considered OCSs. So here are the credentialing elements. So licensure, registration, certification, education and training, completion of the NPDB query. So HRSA has clarified that that is required of everyone, even your medical assistant. So even if there's no license or certification or registrations or unlicensed staff, they still have to be run through the NPDB. DEA, if applicable, you have to get a copy of their ID and basic life support. And for years, we went back and forth with HRSA on basic life support. And everyone is required to have basic life support training. Even your behavioral health staff, everyone has to have it. So privileging elements, fitness for duty, they have to show proof of immunization, communicable disease status. Now, fitness for duty, we always get questions about this. In the toolkit on HRSA's website, there is a link to, and it's also in the guide, there is a link to like a sample fitness for duty form. So what that fitness for duty is verification or attestation by the provider stating that they are fit to handle the duties of the position, both mentally and physically. So I'm the provider, I have to say I am fit to handle the duties of the position. And it's confirmed by a licensed provider, like an MD, NP. And so, in recent OSVs, the reviewers have looked to see how the provider confirms it. And sometimes some of the things that they noted would work in this situation is some health centers have an application or a separate attestation form that the provider fills out that says, I attest that I am, I do not take drugs, I have not been convicted of this or that. So basically a checkoff sheet of various things that they haven't been arrested for drugs or they've charged or convicted, I should say, that, things like that, and that would be sufficient. So for initial privileging, you can rely on their training and education, and if they have references. For renewal, so you really need to assess how they've been doing in your health center. So you could do that by looking through their peer review that they did throughout the year, or you could look at or have a supervisory review or an evaluation. And your policy has to include a process for denying, modifying, or removing privileges. So you have to have files or records for clinical staff. And it's very interesting because the guide goes into detail on what these files should look like. And they said that it should be very neat, and if a credential expires, then you should have the renewed credential included in the file. So basically stack all of these things. So for example, if the license expires in December, you'll print off from your state licensing agency files, the renewed license verification on top. And they said, tabs are great. You should break everything up into tabs. And I know that a lot of FQHCs now have this all electronic and everything is broken into tabs. So it seems like this isn't a heavy lift. Now, if you contract with providers for professional services, you can, in your contracts, have language in there that say that the contracted entity will ensure that their providers that they're sending you have gone through credentialing and privileging processes, and they're assessed as fit to provide services. But the guide states that you still have to review or at least approve and grant privileges to these contracted providers. And one more thing about
that's a significant change as well, right? Because until now, you just had to have the language in the agreement, and you could just rely on that. Now, again, we don't know if this will be final, but based on what's out there, you would have to actually privilege all these people.
Right, right. And one thing that is not in the guide and not in the compliance manual, but we've been seeing in OSVs, as part of the credentialing and privileging review, they want to see that if you're using an outside lab or whatever lab you're using, that they hold a current permit. So they'll ask for a copy of the current permit for your lab. Whatever lab you're using, even an outside lab. So last year and the year before, you had to provide a credentialing list. And so I would get calls frantic about how do we upload our list? It's not something you upload. You have to type in all of these elements into the online application. And they even note in the guide, like, don't try to find a place to upload anything. You actually have to type it out. And then, I don't know if this actually is how it works, but every year it's supposed to populate with this list, and you could go in and remove or add. So these are the elements that you should have prepared to include in your application. So the list has to include everyone, including your employed staff and your contracted staff. So for your contracted staff, you have to get this information from your contractor. And you have to be very careful with the dates. So the dates are important in throughout the application. So for your risk management training, make sure, all training was completed within the last 12 months. Here too, you have to make sure that everyone is up to date with the credentialing and privileging. Okay, so our last topic is claims management. So you have to have a claims management process for addressing claims, including medical malpractice. There's two big elements that should be included in your process, and this is something that you have to upload. So the first is preservation of all health center documents related to any actual or potential claim. So what that means is if you get a complaint, or if something happens within the health center and this could lead to a lawsuit, then you have to have a policy in place to preserve those documents. And so what usually happens is, the claims manager will issue a litigation hold, and that's basically a notice to all the relevant departments or people that might be holding documentation that could be related to this incident. So a notice saying, hold these documentations, do not destroy the documentation, includes medical records, lab and x-ray results, billing records, employment records of the involved parties from the health center, and your operating procedures. So you can't get rid of any of this. And the second element is, if you receive a service of summons or a complaint, your policies have to outline the process where you will immediately send that to the Office of General Counsel, because it's important that they timely find out about these claims so that they can respond within the time frames required. So again, you have to upload this process, and it must include those two bullets. And you shouldn't just write the bullets out. So you should say, the claims manager will send out a litigation hold. So you can, paraphrase, but just the procedure should outline that it's somebody sending the relevant parties a document, a litigation hold, to prevent destruction of important documentation. So as part of claims management, you have to outline any claims that you've had during the last 5 years. This is another one where you're not uploading a document, instead you're just inputting relevant information. For closed claims, you have to specify what actions you took to mitigate this from happening in the future. So it's only relevant for closed claims because you don't want to put any information in here that could be used against you during the litigation. But if it's closed and it's over with, then you can say, okay, we were wrong in this area, or here are the steps we've taken to prevent this from happening in the future. And
right. I just want to add about that, just something that goes together with that, which really maybe is more a QA risk management type issue. You need to be very careful. We get requests often from clients talking about how they want to have a QA or risk management type meeting and talk about a specific case and talk about what went wrong, kind of like an M&M from the hospital. In many states, FQHCs do not have any privilege associated with that. So if you're sitting there talking about how we really screwed up on this case and you're documenting that in minutes, HRSA is going to be very unhappy with you if there's an FTCA case brought about that, and that's through discovery they get that document. So you need to be careful about how you do it. It's very hard to answer it generically because of people from many different states. But if you are going to do that, reach out to us and we can have a conversation with you.
Yeah, I mean, that in many cases in the meeting minutes, I'll see that there's more of a discussion about claims than you probably should have in there. So you have to upload the position description of the claims manager, and you have to also upload the risk manager and the QA director. And what they want to see in all of these is that the duties include the specific functions that relate to the relevant section. So QA should have the QA words in it. So they implement quality assurance, quality improvement, operating procedures and things like that. Or risk manager identifies risk, oversees the risk management plan. And the claims managers, again, you want claims management language in there. And in all three, it has to say that whatever function you're talking about is part of the daily responsibilities. So I'm not sure why that's, those are the buzzwords you have to use, but they want you to say it's part of the daily responsibilities. So an FQHC has to let the public know that you are covered under FTCA coverage. So you could do it on your website, your promotional materials, or posters or other areas within the FQHC. So the guide for the website says it shouldn't be hidden, and they recommend that it should be on the home page. You have to include a screenshot of the exact location where it is on your website, or you attach a picture if you're putting it on promotional materials. Now, something that they've recently started is this FTCA deemed status badge. So if you go on HRSA's website, in the FTCA toolkit, you can use this deemed status badge, and the badge would go on your website. It could also go on your promotional materials. There's guidelines on how to use it, and it has the words that they like right underneath the badge. So that's an option as well, and it looks very nice. Okay, and that's the end of our presentation.
Right, so for once we actually finished on time, so it gives us a couple of minutes to go over some questions that came in. I just put into the chat, but again, if anyone who came on late, we will send out the presentation and the slides in the next few days. I'll take an easier one that someone put up as a question. Going back over the privileging part. Yes. So when you have someone who comes to work at your health center who is a clinical person, you have to go through a credentialing and privileging process, right? Credentialing means that they have all the right, licenses and or certifications, whatever, to be able to provide services. Privileging means, okay, now that they do, what am I going to allow them to do within my health center? Historically, or for the last few years at least, if you were using contractors, you did not need to credential or privilege them, right? You could have language in their contract, right? So let's say you had a hospital that was sending you some specialists, right? So those specialists get credentialed and privileged by the hospital. So as long as you had magic language in the contract with the hospital that said that the hospital has credentialing and privileging, you did not need to do any credentialing or privileging yourself. In this guide document that's up right now, it would require that when you're contracting, you still do not have to do credentialing, but you do have to perform privileging. Meaning you have to fill out a piece of paper that says, while you're here, these are the services you could provide, etc. What you do for your employed providers, you also now need to do for your contracted providers, which seems a little ridiculous, but it seems to be a requirement going forward. Dan, do you want to take one of the other ones?
Sure. So, thoughts on making the risk management program plan a section of the overall quality management quality assurance program plan, because they overlap. They do overlap. And, in our policies that we draft, in many cases, we include risk management there, but we include it, we'll include some language about risk management in the quality assurance, quality improvement plan, and we'll attach it as an exhibit, but I would have these as separate documents. Your risk management plan, now they're saying that it has to be a separate document that has to go to the board, and the board has to review the plan annually. Your quality assurance, quality improvement plan is also board approved, but it's approved once every 3 years. So it seems like they're with the risk management plan, they want the board to have a separate document that they look at annually and see if any modifications are needed. So I like to give them, if HRSA says they want X, I like to give them X. But I agree with you, there's so much overlap, and in fact it was acknowledged by HRSA that, well, in the guide that there was a lot of overlap.
Okay, I think maybe one last question. Someone asked about closed claims. So basically closed claims means anything that either HRSA has closed or that there's no possibility of the claim going forward anymore. Right, so if there's any possibility of being a court case about it, then it's not considered to be closed, or if there is an active court case going on, or you're waiting for HRSA to step in, then those should not be included. But if it's completely done and there's no possibility of any future action on it, then it would be considered to be closed. I know we did not get to all the questions. We will try to respond to everybody else individually. Thank you for joining us today.
Thank you.